afternoon, everyone. Very much for the opportunity to be involved in this excellent course. So pancreatic cysts are increasing in prevalence, and this is mainly because a lot of people are having CT scans or MRIs for other reasons, and pancreatic cysts are discovered incidentally. And as you can see, the prevalence of pancreatic cysts tends to increase with age. There are numerous types of pancreatic cysts, but the ones we come across most commonly are pseudocysts, which develop after an attack of acute pancreatitis, serous cystadenoma, mucinous cystic neoplasms, or IPMNs, either the branch duct type or the main duct type. It's important to classify which type of the pancreatic cyst you're dealing with because the neoplastic and malignant potential differs between the various types of cysts. So pseudocysts are, of course, non-neoplastic, but all the other cysts are neoplastic and have malignant potential. Serous cystadenomas are, majority of the time, they're benign, but all the others do have some malignant potential. So the numbers vary across the literature, but in general, main duct IPMN has the highest malignant potential, up to 70%. The mixed type of IPMNs, so involving both the main duct and the side branches that then have the next highest potential, followed by branch duct IPMNs, mucinous cystic neoplasms, solid pseudopapillary neoplasms, and cystic neuroendocrine tumours. So once we come across a patient with a pancreatic cyst, how do we manage this problem? In general, it is a balance between surveying the cyst and sending the patient to surgery. Now, as you saw in the previous slide, not all cysts are malignant. In fact, majority of them are not malignant. So we have to carefully select which patient needs to be sent off for surgery because pancreatic surgery obviously is quite significant and associated with significant morbidity and even mortality. So in this situation of pancreatic cysts, EUS morphology is extremely helpful in identifying what type of the cyst we're dealing with, and then subsequently determining what the malignant potential may be. So serous cystadenomas, as I mentioned before, majority of these are benign, but there is a malignant potential risk even in these particular lesions. They tend to be more common in females, ratio of almost triple of that of men. When we do the imaging, we find that it's generally not connected to the pancreatic duct. There is often a central calcification scar. And when you do the EUS, you can see this honeycomb microcystic appearance. And after using your Doppler fluid, also help delineate the borders of the lesion. So moving on to solid pseudopapillary tumours, these are actually often found in young women. Majority of them, more than 90%, are in young females, and they do have a malignant potential of up to 15%. Once again, on the imaging, you tend not to see these cysts related to the main duct, and they tend to have both a solid cystic component. So if you've got a young female patient with a large solid cystic lesion, then solid pseudopapillary tumour is usually high on the cards. So on the left here, we have an EUS image of one of my patients, a young 24-year-old woman who had this cyst incidentally discovered on a CT scan done for investigation of kidney stones, and EUS and biopsy confirmed the diagnosis, and she went off to have surgery. So moving along, cystic neuroendocrine tumours. Now, these cystic lesions don't tend to have a gender or an age predilection, and they're frequently seen in patients who have the MEN1 syndrome. The malignant potential of these lesions is quite variable, and on imaging, up to 18% of these have a cystic feature rather than a solid lesion. So again, when you do the EUS, you may see a solid cystic lesion, and of course, EUS-guided biopsy helps confirm the diagnosis. Mucinous cystic adenomas are entirely seen only in women, and they have a malignant potential of up to 18 to 20%. Again, these are generally not connected to the main duct and are most commonly seen in the distal pancreas, so in the body and tail. So it's a unilocular lesion in the body and tail, and in a woman, this is most likely to be a mucinous cystadenoma. Now, branch duct IPMNs are one of the most commonest things you will generally see. Men tend to have them more than females, and malignant potential is quite variable. And I'll talk a little bit more about when these lesions are starting to turn malignant and how we can identify that. So usually you'll see small or large cysts which are connected to the main duct. they tend to be multilocular or they can be unilocular, so it's not one or the other, but they do tend to be multiple. So you often see multiple cysts in the one patient. Now, main duct IPMN is when we see a complete dilatation of the main pancreatic duct, and it's very easily diagnosed in both MRI and CT. And as you can see on the EUS video shown here, this is actually a patient of mine that I saw this morning. She has main duct IPMN, and you can see the ampullary image as well, shows a classic fish mouth appearance where you see the MUCIN exuding from the main pancreatic duct at the level of the ampulla. These have a very high malignant potential, greater than 70%. Now, when assessing these cystic lesions, we use a combination of EUS, MRI, and CT scan, and you'll see on the table that a lot of features are very easily identifiable on EUS, but not so much on CT scans. MRI also has a very high predilection to being able to determine some of these features, but EUS is really the best test in trying to determine these certain characteristics in pancreatic cystic lesions. Now, as we mentioned, the main issue with these lesions is that they do have cancerous potential. And how do we know if a cyst is turning malignant? So one of the main things that we look at is, over our years of surveillance, is the cyst size and if the cyst is growing. And the cyst growth can be measured in millimeters per year. And if there is increasing cyst size growth, or if the cyst is greater than 3 centimeters, then these features suggest to us that there may be malignant potential. The other things to look for when you're doing EUS of these lesions is high-risk features which suggest malignant potential. And these are often seen on EUS alone, not very well seen on CT or MRI. So things like an enhanced solid component within the cyst, or a thickened cyst wall, or a nodule, or a mural nodule within the cyst as well. And of course, again, the advantage of having EUS is that we can actually biopsy these lesions at the same time. I won't be talking about FNA today because I know there's another speaker later on who will be speaking a little bit more about that. So again, this is a nice image of on the left-hand side, you've got a MUCIN ball versus a mural nodule on the right-hand side. So under EUS, you can use the Doppler flow to see that the mural nodule often does have Doppler flow, and the MUCIN ball will not have any Doppler flow. And we can also pass a needle into the lesion, and the MUCIN ball will usually disintegrate or disrupt, whereas the mural nodule won't, and you'll be able to target it for biopsy. So, as has been highlighted in the presentation, that we are constantly trying to determine whether there is a risk of cancer in this patient with the cyst and whether or not the patient needs to move on to surgery. So you do need to work closely with a team of excellent radiologists who can provide good quality imaging, particularly with MRI or MRCP. And of course, you need to work closely with your pancreatic surgeons and the pathologists, because when it comes to biopsying the lesions, they need to be assessed carefully to see if there is a confirmed diagnosis which warrants a patient moving on to resection. And hopefully in due course over time, we will have availability of biomarkers which will help us determine this malignant risk within the patient's pancreatic cyst. So in summary, EUS of pancreatic cystic lesions is important for not just diagnosis, but also the morphology that we can see during EUS helps us stratify the risk of malignant transformation in these patients, in particular things like mural nodules, thickened wall, or development of a mass. Management of these patients of surveillance versus surgery, so it's important to work closely in a multidisciplinary team. Thank you.